Good afternoon, and thank you for joining the RLS Foundation's webinar titled Hormones, Sleep, and RLS in Women. My name is Carla Diezenkowski, and I'm the Executive Director of the RLS Foundation. Before we begin, please be aware that all attendees will remain on mute during this hour. We thank you for the questions submitted with your registration. Our speaker will answer as many questions as time allows at the conclusion of our presentation. The surge in the use of web-based programs during the COVID-19 health crisis has created a strain across the internet. If you are experiencing technical difficulty, you may switch to audio only by calling into the number listed on your email confirmation, as it uses less bandwidth, and be sure that your webcam is turned off. We thank you for attending and appreciate your patience and understanding with any technical difficulties that may arise during today's webinar presentation. After the webinar, you will receive an email with a link to the webinar recording. It will also be made available in the member portal section of our website. If you're not a Foundation member and if you would like to view this and other recorded webinars, we invite you to become a member today by going to rls.org/join. As always, individuals suspecting that they may have RLS should consult a qualified healthcare provider. Information offered in this webinar is for informational purposes and should not be considered as a substitute for the advice of a healthcare provider. Our speaker today, Dr. Jennifer Hensley, is a certified nurse midwife and women's health nurse practitioner. She teaches at Baylor University, Louise Harrington School of Nursing in Dallas, Texas. She has built her clinical scholarship on restless leg syndrome during pregnancy and sleep disorders in women across the lifespan. She is an active member of the RLS Foundation's Scientific and Medical Advisory Board, serving on the Quality Care Certification Committee and the Medical Bulletin Committee. Thank you for sharing your time and expertise with us today. I now invite you to begin your presentation.
Thank you, Carla. Some of you attending may think, what's a midwife doing talking about menopause and restless legs? Well, nurse midwives actually see 50% of their time in the clinic, GYN patients. And over the course of my 45 years in clinical practice, I can't tell you how many women have presented with complaints of I can't sleep or my legs hurt, and then you have to tease that out, etc. So I'd like to let you know that aside from being fully qualified to see gynecologic patients, I myself am postmenopausal and have my own experience with this situation. And to make some of you comfortable, I most likely do have an aspect of RLS. Happens infrequently sometimes in the middle of the night where I just have to get up and move. Never enough to thankfully have to take medication for it, but I do understand that sensation to just have to get up and move. I have no financial conflicts. There are some abbreviations that I am going to use throughout this presentation. This will be available to you after the webinar, and you may want to actually Google the North American Menopause Society or ACOG and WPSI, the Women's Preventative Services Initiative. I did want to start and make this entire webinar about the whole person. Are you making certain that all of you is healthy and not just addressing the RLS symptoms? Then I was given the questions that you all asked, so I added some more information. I will talk quickly and happy to answer questions at the end. And probably should put my timer back on. So we go 60 seconds per slide. All right. I really do want to talk about the whole person during the peri and the postmenopause. And I would like all of us to remember that genetics are strong. RLS has a strong genetic component. The timing of your menopause and probably many of the symptoms that you experience are also genetically determined. It occurred to me that not everyone who is attending might know what restless legs is. So here's our introduction slide. RLS is a chronic and progressive both sensory and motor disorder that can begin at any time during life. We know that there is a genetic component, and we also believe that it's due to a dopamine deficiency, that's our feel-good hormone, and a brain iron deficiency, which if we can get our blood iron our iron stores up high enough, might abate some of those symptoms. There is no one test that will let us know that you have RLS, such as doing a complete blood count and determining that you're anemic. So we need to do a clinical diagnosis. Do you have an urge to move the legs? At rest, does this urge get worse? Does it get better when you get up and are active? Is it worse in the evening and the night, which implies a circadian rhythm? Worse at night, better in the morning. Worse at night, better in the morning. And the sensations that you feel, the urge to move, is not solely caused by another medical or behavioral condition. So for those of you attending, I'm really, really sorry. I have no magical answers for menopause and no magical answers for RLS and menopause. There just is not that much research out there. When it comes to looking at pregnancy and RLS, pregnant patients are a vulnerable population, and we can't really study them. It takes a lot to get pregnant women enrolled in any trial. Because menopause is so personal for each one of us, and the symptoms and the changes that go on, it's really hard to come up with one answer that fits all. So most of what we offer and what I'm going to offer to you today will be trial and error, but maybe I'll give you a little bit more information to help you ask questions that will help you get what you need and want. I would encourage you, in thinking of the whole person, to go to the NAMS, or North American Menopause Society website, and take this quality of life instrument. You don't need to be a member to take this. There are 27 items on it, and I think it's important, just as a check for a moment, to think of you, the whole person. What else is going on in your life? So I did put this here as a check for all of you, not all of you as in a collective, but all of you from head to toe, including your spiritual well-being. I would like to put some caveats in here. When we look at hormones and hormone levels during the reproductive years, our menstrual cycle happens every, ideally, 28 days, and the estrogen is going to go up and down, and then it's going to peak, and then it's going to fall. The range of what's normal is so wide that we cannot specifically say all women need this value. That makes it very difficult for me to tell you what your estrogen level should be or what your progesterone level should be. We only know what the mean is, or the average. Other things that really affect production of reproductive hormones are our weight, the percentage of body fat that we have. We know that women who carry more weight, and I'm not talking muscle, I'm talking adiposity or fat cells, have higher estrogen levels. I'm going to talk a lot about the fact that fat cells actually aromatize or create a weak estrogen out in the periphery of the body. And those estrogens, or that estrogen, estrone, is very androgenic, meaning male-like, and gives us male characteristics. So the more body fat you carry, the more estrone your body will produce. We each have a different lifestyle: smoking, exercise, alcohol. Those factors cannot be teased out so that I tell you there's one correct hormone level for all persons. We all have different diets and genetics. And to the genetic end, we all have different liver enzymes. Right now, we know that if we're going to put you on an antidepressant or an HIV medication or a medication to stop blood clots, we can do a genetic test and see whether or not the medication is right for you. And we're just on the brink of pharmacogenomics. We're not there for all of the medications, but we're beginning. So at some point in time, not in my lifetime, but in lifetimes behind me, my patients, or who would have been my patients, are going to show up and hand me a sheet of paper and say, these are the drugs I can take based on my genetics and liver enzymes, and these are the drugs that I can't take. For right now, for most of what we do, it's trial and error. There's also just a personal threshold for acceptability of what's comfortable and uncomfortable. And then what makes it even more difficult to try and find a perfect answer to help with symptoms is medical comorbidities. Age is huge. And then, of course, I needed to put assigned gender at birth because I don't want to forget that there are some persons out there transitioning from either to either male or female, taking hormones that are exogenous external pharmaceutically made hormones that may impact RLS symptoms. And I haven't seen any research on that, and I'm sorry I cannot speak to it. So let me tell you how many hormones you have in your body, pretty much. We have estradiol, estrone, and estriol. Estradiol is strong. It is the predominant hormone during our reproductive years, which are about 35 to 40 years. It is produced only by the ovaries. And interestingly, during the reproductive years, even our internal production of testosterone and DHEA, okay, is actually in the ovaries converted from an androgenic hormone to estradiol. Estradiol is wonderful until it's all gone. Before puberty and after menopause, the only hormone available to us is estrone. It is a weak estrogen. It is far more androgenic, and it is created by aromatization, not created in the ovaries. And the only time we ever get estriol is during pregnancy because it is produced by the placenta. So pre-puberty, menopause, and post, estrone. Why is estradiol such a good estrogen? Well, it's responsible for everything that we feel is right with ourselves when we're in our 20s, our 30s, and maybe up into our 40s, before we feel as though we're starting to get older. We have good mood, good skin, our breasts are perky, unless you breastfeed, healthy vagina, healthy libido, our teeth are happy. Almost every part of our body is happy. However, for those who are predisposed, this estradiol, the good estrogen, can cause blood clots, hormone-dependent cancers, hormonal headaches, and hypertension. So when we talk about hormone levels, we need to look at comorbidities and genetics as to when to prescribe, when not to prescribe, and how to treat the patient. So bottom line for puberty and menopause is we don't know what starts it and we don't know what stops it. Not really. We have lots of theories that I could spend an entire 3 or 4 hours on, but the bottom line is we don't know the trigger. We do know that it all starts in the central nervous system. We call it the hypothalamic pituitary ovarian axis. So the hypothalamus and the anterior pituitary gland are up here in the central nervous system, and the ovaries, of course, are in our reproductive organs below the umbilicus. The important thing here is to recognize that RLS etiologies are also in the central nervous system. So you cannot start changing messages, chemical messages in the brain from here to there without upsetting some sort of apple cart in another region of the central nervous system, which may in part explain why RLS symptoms don't appear until this part of life, or they're not as strong during that part of life. So let me give you some of the studies I found on RLS and estradiol, which pretty much is, we don't really know, but may help at least one person. First, it's very complex. The reproductive hormones and iron, because iron metabolism goes throughout the body, but for RLS sufferers, we need a receptor and enzymatic functions that will take the iron across the blood-brain barrier into the brain and the central nervous system. But let's suffice it to say that high levels of estrogen can be a dopamine antagonist. You need iron to produce dopamine, and high levels of dopamine will therefore abate your RLS symptoms. So when you have lower dopamine levels, your RLS symptoms in one sentence are going to be worse. So if you have high estradiol, if it antagonizes dopamine, then your RLS symptoms will be worse. So could that be an explanation as to why at the end of pregnancy, RLS symptoms get worse? Well, that I'm not certain. To me as a midwife, that makes perfect sense because the estrogen levels start to decline closer to term. Could it be that the baby is siphoning off all of the maternal iron stores? I'm not certain we have a 100% answer. One researcher, Baker, put out that maybe it's not the higher estradiol level, but maybe it's just changes in estradiol. So we already know during the menstrual cycle, estradiol levels, because estrogen is being produced by the ovaries, starts to climb, then it hits a peak, there's ovulation, and if there's no pregnancy, then it comes down again. Excuse me. That might explain why during menopause and maybe pre-puberty, when the estrogen levels are very, very low, symptoms can either get better or worse for some. And I'm going to say, I don't know why. I'm just going to blame it on genetics. I do, however, wonder if a young person of reproductive age who had horrible RLS might not benefit from me turning off the fluctuations in estradiol by giving them birth control pills and having them take one every single day and never allowing the fluctuation. Because we are so specialized, we have, orthopedics, and somebody only does hips and somebody only does knees. It is not likely that a sleep expert is going to send any patient to me for birth control pills. So that's why I'm trying, hopefully, to empower you to think whole person. What can I do to take charge of my my condition and ask some other questions? Not that you haven't already, but I'm hoping to give you some more ammo. All right. By the way, at some point in time, your ovaries will give their notice that they are quitting and retiring. The average age in the US is 52.5 years, and if you have diabetes or smoke, it happens earlier, maybe up to 10 years earlier. That means 1/3 of our lives are going to be spent in menopause, and that's a really long time. I mean, what's the alternative? But 1/3 of your life in menopause is worth taking note and taking charge. And I wanted to show all of us during reproductive years, please look on the left over there. At 35, the peak during ovulation of estradiol is somewhere between 150 and 300 picograms. That's a huge range. So anything in between there is normal. And P.S., it's not the same every month. It changes every month. And why does it do that? oh, are you a pound up, a pound down? Did you exercise more? Do you have more fat, less fat on your body and more muscle? Stress, lack of sleep, etc. But once the ovaries retire, that's the end. And in the menopause and postmenopause, please note that the average value of estradiol is 10 picograms. That's a huge difference. Please also note that during the reproductive years, only 30 to 40% of the estrogens in the body are produced by peripheral aromatization in our fat cells. After menopause, 100%. The ovaries don't work anymore. Just some of you are going to want to know who might have undergone infertility. The follicle stimulating hormone during the reproductive years should be very low because it should not take much for the anterior pituitary to send a text to the ovaries and say, time to produce an egg. When the ovaries start to become resistant to responding to the FSH level, FSH will start to rise and rise and rise. And pretty much in reproductive terms, an FSH of 5 is great. Once it hits 30, it's a done deal. When you're in the menopause, it's not unusual to have an FSH level in the hundreds. So as the estradiol comes down, the FSH goes up. What changes in menopause? Everything. Our thyroid, our skin, immune system. I have put in blue what I think is really important to help empower you. Many mood changes occur during menopause. Is it only because you're going through the menopause, or are there other things? And I would encourage you to go back and take the quality of life test. It is not unusual that I get a lot of patients who are depressed during menopause. Some of this can be from relational turmoil because as the estrogen level drops, vaginal health goes by the wayside, intercourse becomes uncomfortable. That's going to depress people. There are things we can do, hang on. But other parts of our body age as well. Our GI tract, we can't absorb things like we used to. We can't absorb iron like we used to. We can't absorb calcium, etc. So please be aware as the years go on, all of our body from head to toe starts to age. Now, hot flashes are kind of unique, and we're not talking about hot flashes specifically. We're talking about RLS and menopause, but I'm here to tell you, although most hot flashes, also known as vasomotor symptoms, occur during the day, even last night, 20 years into menopause, I woke up in a soaked bed. Why does this happen? Why last night? We really don't have any idea. But all of a sudden, the body vasodilates and pours out, sweat. And it happens for a brief period of time, and then it's over. And it can continue for decades into the menopause. Yay. And what we do is treat based on quality of life and symptoms. And so to that end, we have categories. Do you have, mild RLS? Do you have mild vasomotor symptoms? Is it worth treating, or can you live with it? We want to target and treat persons whose quality of life is not good because of their symptomatology. Well, there is one answer, and that would be to get an ovary transplant. But the problem with that is that I have more and more graduate students in my program who are in their late 20s and 30s running down to repro endocrinology and harvesting their eggs and freezing them for a later point in time, like their 40s when they might want to become parents. So now I don't think that that's going to fly, the ovary transplants. That's just an FYI. So what are benefits if RLS gets worse? during menopause, is there a benefit to hormone replacement? Or if your night sweats, vasomotor symptoms keep you up at night and make everything worse, what can we do? Well, yes, HRT has a role, hormone replacement therapy. It will suppress hot flashes. It will reverse shrinking of the vagina and the dryness. It will help with those recurrent bladder infections, and it will enhance bone mineral density and help, put a halt on osteopenia, but it's not a cure for osteoporosis. It might also help with depression and a few other things. However, hormones are nothing to be taken lightly because they have adverse side effects. But before I mention that, let me tell you that there are plenty of choices, and your sleep expert is not going to help you with that. An gynecologist or a nurse midwife or women's health NP who does a lot of gynecology can help you. We have 4 different estrogens, bioidenticals, pelleting, and different progestins. How do you know which one to take? Which one's the best? There is no perfect answer. Pretty much, we go with what your insurance company will cover for you. And the rule is always start low, go up slow. Many of you might be thinking, well, what about the Women's Health Initiative? I thought they stopped that because everybody was dying on estrogen and progesterone. No, 20 years later, we have redone the data, and the persons who were having serious adverse events from taking estrogen and progesterone pretty much had started their hormone replacement much later in life than the average age of menopause. So to that end, NAMS has put out recommendations. First, if you have a uterus, you need to take progesterone. You cannot take estrogen alone because we can set you up for endometrial cancer. No uterus, estrogen alone is fine. Uterus, estrogen, and progesterone. Otherwise, NAMS is certain that HRT is safe and way underutilized and that the benefits outweigh the risks. We want to start with healthy women within the first 10 years of menopause who are less than 60 years old. The risk of coronary artery disease, stroke, blood clots, and dementia goes up after the age of 60. Now, use of the very lowest dose available or using a patch, transdermal, may mitigate this risk, but I think you would be very hard pressed if you're over 60 to get anyone to prescribe estrogen for you at this point. There are some considerations. We cannot provide estrogen to women who have an estrogen-dependent cancer or a blood clotting disorder. If the only issue is genitourinary symptoms of menopause, recurrent UTIs and uncomfortable intercourse, we can offer you only local estrogen cream or pellets. However, I put this in here not to talk about menopause and estrogen, but to let you know very small amounts of this are absorbed through the vaginal mucosa. And during trials, we meaning researchers, have been able to find a level of pharmaceutically made estrogen in the bloodstream. So if your body is one of those exquisitely sensitive to any fluctuations in hormones, even a vaginal preparation may affect you. So I get this question with every peri and menopausal person that I see. Well, I'm not afraid of menopause. I don't want to have my period anymore. I'm so excited. I'm just going to take estrogen. Well, here's the problem. While estrogen replacement can help with things, it cannot turn back time. All right. Once the ovaries are offline, the estradiol production is gone. I don't care if you take estradiol perfectly manufactured from a plant or in a lab, it's going to be converted to estrone. the androgenic-like hormone. So you can pay thousands of dollars for your estradiol, or you can take, if you're old as I am, Premarin, which is conjugated equine estrogens. They're both going to be converted into estrone. And that is the hormone that has androgenic properties that include male pattern baldness, weight gain, and new hair growth in places. We women really don't want that. So then what about bioidentical hormone replacement? Isn't this better? I mean, shouldn't I, if I want to get my estrogen level up more to what it was so that my RLS symptoms might be better, what about bioidentical hormones? Well, I'm sorry, but it's not FDA approved. And the biest and the triest may be more similar to hormones made by the body. But again, once the ovaries have retired, this too will be converted into estrone. And if you have a uterus, you need progesterone. What about pellets? Well, the BioT pellets are inserted into your upper buttocks. And it's true. Salivary or blood levels are monitored so that they stay within the normal range. And you keep going back to get more pellets until your symptoms are better. Now, typically we're not talking about RLS, we're talking about depression and feeling better, etc. But I'm here to tell you, if you're feeling good about life, I think RLS symptoms can be just a smidge better. There is a problem, however. Not only is this not FDA approved, but if you're in the menopause, this is still going to be converted to estrone. It seems to work a whole lot better for women who are in their late 30s, early 40s, and in the perimenopause and not quite yet menopausal period. It's not covered by insurance, so it's about $350 every 3 to 6 months. And here's the biggest problem. If you don't like the pellets, you are stuck with them for 3 to 6 months until they dissolve and are out of your system. You cannot go back and take them out. Otherwise, if you don't get an infection at the site of pelleting, which is rare, but it does happen, I've heard colleagues say that there's great success. So we tell my students all the time, we can't fix one thing without breaking another. So is it worth the risk? And if we're talking hormones or pretty much any medication, it takes at least 6 weeks to really get the full effect. If we're talking about hormones and wanting to take those to see if it will make you feel better, please know that they are expensive. If your insurance does not cover it, hormone replacement is more expensive than birth control pills. So this is just a Jenny thing for the pharmaceutical companies out there, if anyone's listening. We can give a tablet for erectile dysfunction for 25 cents. But when it comes to vaginal estrogen to help a menopausal vagina, that tube is $200. So you go figure out what's wrong with that picture. Now, this is what you want to know. How can I help you? First, please understand it's not that easy to help persons in the menopause, and we need to work together. We need to partner with you, and we need to empower you, because as we get older, we collect comorbidities, and comorbidities mean more medications, and more medications mean more drug interactions, which either accelerate the effects of one or all, or decelerate the effects of one or all. So to this end, I'm asking you to please, if you're not already doing so, seek annual preventative health care so that we can get ahead of those comorbidities if they should develop based on your genetics. Now, this is for average risk persons, okay? Not high risk persons. What does a mammogram have to do with my RLS? Well, probably nothing, but if you're going in for a mammogram, at least you're getting your blood drawn. And we can look at your blood count. Are you anemic? We can look at your thyroid panel. What does a pap smear have to do with it? Well, probably nothing, but what's a pap and my RLS got to do with anything? Nothing, but at least I'm seeing you and I can ask you questions. You can ask me questions. Any bleeding we want to know about, because that's blood loss. It lowers your blood stores and that's going to affect your RLS. And we do have different guidelines, national guidelines. If you're a women's healthcare expert like myself, you want to go with ACOG and the lower age limit. I want to start my patients with a mammogram at 40 and a colonoscopy at 45 because I'm a specialist in that department. The other guidelines are based on population across the United States, not specialties. Thyroid regulates all metabolism. If this is off, everything else is going to be off. Thyroid stimulating hormone comes out of the pituitary gland, just like FSH and a lot of other things, and it talks to the thyroid gland and talks to the rest of the body. If that's not working, many other things are not going to work. And then if we know that you have a lipid problem or a blood sugar problem or you're anemic, we either need to help you correct that or give you medications that most likely will affect some of the medications you take for RLS. A complete metabolic panel is essential as we age, and we should do this annually to make certain that our liver and our kidneys are functioning properly. And one thing that I think many of our PCPs might forget is the vitamin D level. It's an anti-inflammatory. It really, really helps your liver. Ask for a vitamin D and a ferritin. And of course, because we want to get the whole person, talk about sexual satisfaction, interpersonal violence, and incontinence. We don't want you to keep things stored up that can start ruminating in the middle of the night. So discuss everything with your primary care provider and maybe even your sleep expert. And say, I heard a midwife say this. Well, then come see me. We know that there are plenty of medications that stop the absorption of iron, small intestine bowel overgrowth, and all of those antibiotics that you're going to need to take for this, or H. pylori, etc., are going to upset things until we reestablish your normal bowel flora. Heavy menstrual bleeding in the perimenopause, I see a lot of this. I put a lot of women on birth control pills to stop this bleeding, and most of them don't want to take it because they've had a tubal ligation. I'm like, you're anemic. I don't know how you're walking around. But specifically, if you have RLS, we want to save every last red blood cell that we have. Please let me help you until the ovaries are really done and retired and you're not going to have monthly menses anymore. And bleeding from anywhere, please bring up to your PCP. So here's how I can help you. Don't forget about iron supplementation. Check a complete blood count and a ferritin. Not only do RLS sufferers need a higher ferritin level for the iron to cross the blood-brain barrier, as we age, we get age-related anemia. Yay. Make certain you're taking your iron correctly, once a day or every other day, on an empty stomach, and nowhere near before or after you've taken an antacid or a dairy product. Gabapentin helps both hot flashes and RLS. This works for many patients that I have. Not all patients can tolerate gabapentin, but this is a 2-for-1, hot flashes and RLS. What about hot flashes and antidepressants? We know for a fact that paroxetine, also known as Paxil or marketed as Brisdel, helps with hot flashes, but that's an SSRI, selective serotonin reuptake inhibitor, and we know that's a dopamine antagonist. The better choice, if this is what you wanted to try, would be Effexor or venlafaxine, because it's not as much as a dopamine antagonist. It's not FDA approved for this, but it would really help not lower your dopamine and antagonize RLS symptoms. We have no literature that Wellbutrin helps for hot flashes. Clonidine is an old antihypertensive or an alpha adrenergic, and it's good for three things: hypertension, your hot flashes, and RLS symptoms. It's old, but if it works for you, it works. I've used this, not personally, but in some patients, and they seem to be fine with it. Very low dose, remember. Vitamin D, check your level. Remember, it's anti-inflammatory throughout the body. And you need your liver. Your liver metabolizes medications that you take. And we know they fluctuate on a daily basis. So you want a healthy liver. Keep your calcium level up, because here's a real bummer. When we fall and break our hip, 50% of us are never getting up again on our own. We're going to need someone else to help us live our lives. For RLS sufferers, that I cannot even imagine, for those with severe RLS, not being able to get up by yourself and walk around. Exercise. Some of us feel better after we exercise, and sleep better. And sleeping well is really important. So here's something that women come to me and say, I can't sleep. And then I go through the list with them. When do you like to sleep? Well, I like to go to sleep at 2 o'clock in the morning, but my partner wants me there at 10 p.m. Why do you do that then? Go to bed with your partner until they fall asleep and then get up. First, we need to honor our whole person and know that as we age, we become more advanced, which means we want to fall asleep earlier. I'm at the point in my life where if I want to fall asleep at 8 o'clock, I can. Not all of us are there that can do that, but please think about when's the best time for you to sleep and honor your circadian rhythm. It's genetic. Make certain you do not have any other sleep disorders. You might have obstructive sleep apnea. And then be safe as we get older, and even older in our, late 70s, early 80s, early 90s. The medications that we are taking now in our 50s and 60s for hyperlipidemia and hypertension, we can decrease as we get older. So maybe we're being over-medicated. And prevent the falling. Move those area rugs and have good lighting. So just a study or a statement, because I know some of you want the evidence. So the Canadian longitudinal study here, one of you asked the question, does RLS get worse in menopause? According to this study of over 6,000 women, the answer is no. Falling asleep and staying asleep, yes. And there's literature out there that contradicts this. Some literature says PLMs get worse. And the one study I found that might actually be the best for hot flashes, insomnia related to hot flashes, and might help RLS if we're going with the estradiol level theory or estrogen level, would be very low dose estradiol and Effexor or venlafaxine every day. Okay, I would be willing to try that for a patient who is perfectly healthy, knowing that if they had a uterus, they're still going to need the progestin component. I would be remiss, having come from Colorado, if I did not mention that there is a study ongoing now to see if cannabis helps for symptoms of menopause. We know that there's always a question about cannabis and RLS. I'm not going to comment on that. I'm just telling you that NAMS is looking into it. And if you wanted other non-hormonal things to help with your hot flashes so that you didn't add another medication. These are some of the management options that NAMS has decided have the evidence, and that would be cognitive behavioral therapy, hypnosis, and of course, Paxil, which we don't want to use for for RLS sufferers, but gabapentin and clonidine work. See, NAMS is recommending it, and we know the gabapentin and clonidine are good for RLS. I put some non-endorsed recommendations in here because it might work for one person, with the caveat that a lot of what we do is 40% placebo effect. If you really believe it's going to work, it's going to work. And thank you.
It was a great presentation, Dr. Hensley. We'll go ahead and start with the Q&A. Gosh, I've got words issues today. Do any common OTC supplements taken to lessen symptoms of menopause cause increasing RLS symptoms, such as black root cohosh?
Yes, I saw that question there. There is no study. There was no literature about that.
Okay. We talked about this, but we had 160 people billed throughout, so some of this will be a reteach for you. Do vaginal hormone? Yes.
Carla, can I just mention that when it comes to, and this is a problem in pregnancy with the cohoshes, there's no way to study this because it's not FDA approved and things don't go through a pharmaceutical company. So you could get one set of the tea and it'd be very potent, and another set and have it very weak. And that's part of the reason we can't study it.
Okay.
Dosaging is different depending upon where you buy it and what time of the year you buy it.
Okay. Do vaginal hormone creams affect RLS symptoms?
No, nobody has studied that. By cream, we're talking the vaginal cream?
Mm-hmm.
No, that has not been studied.
Do you think there's a, oh, I'm sorry, go ahead.
No, I mean, I could just stop and say, that's not been studied and it hasn't, but a very small amount is going to be maybe absorbed through the vaginal mucosa. So the question is, could get better, could get worse if you're very, very sensitive.
Do you think there's a relation? Oh, I'm sorry.
No, I'm sorry. I was just going to say that would be part of the trial and error.
Do you think there's a relationship between cortisol levels and RLS?
I would leave that for one of the physicians on the scientific board. Our I mean, if there was, but here's the question. When I read these questions, I couldn't really answer them because I needed to know whether or not what the audience wanted was, how can I make my cortisol level stay stable, and you can't, or whether they wanted a scientific discussion of it. So cortisol, a certain amount of cortisol, of course, is going to make us feel better because we use it to stop, asthma exacerbations, etc., other things. But our natural cortisol production is going to change throughout the 24-hour period and from day to day. There's not a pill to make it stay the same.
Mm-hmm. Does the severity of RLS vary with the menstrual cycle, and if so, how?
I tried to address that, and the answer is, according to the study from 2020 that's on one of the slides, yes, it does. When the estradiol is going up from menses to menses, the estradiol level is going to go this way, and then if there's no pregnancy, it's going to bottom out. As the estradiol level rises, it should get, RLS symptoms may get worse, which would be a reason to give birth control pills and flatline the estradiol level, if that makes sense. When we give birth control pills or combined oral contraceptives, it knocks out the natural fluctuation in the hormones during the menstrual cycle. Or suppresses them would be a better term to use. So theoretically.
Have you heard of RLS beginning in perimenopause?
It has not been studied. I'm sorry. A lot of this has not been studied, but if we go with the theory that changes in estradiol are going to affect dopamine production and iron metabolism in the brain because it's very complex and convoluted, then it would make sense that as the estradiol is withdrawn, there are changes. Or it could be that this was already genetically determined, that at this time in life the RLS symptoms would begin because somebody in the family had that happen to them, you know, lifetimes before.
I'm 51 and started with RLS 2 years ago. I'm experiencing menopausal symptoms as well. Does RLS eventually go away after menopause?
That cannot be answered. The answer is maybe, but there's no study that says after you've had the final menstrual period, 12 months later, when we actually call you postmenopausal, that RLS stops right then. Probably not. I think the better thing to do would be to go get a ferritin level checked, see what your iron body stores are like, and then think about your quality of life. Are you having RLS symptoms enough where you are getting like zero sleep and you need perhaps medication assistance, or we just need to beef up your iron stores a little bit with iron supplementation? It's about much of what I do and much of what sleep patients come in for is about quality of life and how severe the symptoms become.
I am on, go ahead.
Oh, no, go ahead.
Okay, I was going to start another question, but do you need to, did you have another comment on the prior question that you'd like to finish, Jenny?
No, I'm done.
Okay. I am on an estrogen inhibitor, anastrozole, for cancer. How will this affect RLS symptoms? I may have pronounced that incorrectly, but.
Right, so we're probably talking about breast cancer. This is going to be very individual. Again, it's going need to know how old this person is. It's going to be different if it's an aromatase inhibitor or any one of the other medications, and how sensitive that person is to fluctuating estradiol levels. If young, you know, we're talking 5 years. I wish I could answer that. There's so much more I need to know, because are we talking about prophylactic therapy with a preventative mastectomy and 5 years of tamoxifen or something else, etc. And then it's going to come down to being how the individual body deals with the change in estradiol, because anybody on an anti-estrogen is going to go through pseudo-menopause. The estrogen level is going to be We want it to be as low as possible.
I had a complete hysterectomy at age 40 and I'm now 65. How does surgical menopause affect my hormone level? I take HRT twice a week.
How does it, well, it, not, I'm trying to second guess what the question for that is. All right, at the age of 40, would not have gone through menopause yet. So we definitely wanted to put this person on hormone replacement for bone health and other health. But now that we've passed 52, she would fall into the same group as everybody else because she's past that point. Does that make sense?
Mm-hmm.
So taking estrogen at 55 would fall into the rules of NAMS, or the North American Menopause Society. I'd keep, if it makes you feel good, I'd keep taking it. Because now it's considered estrogen replacement for menopause, not estrogen supplementation for surgical menopause. Something that we created.
Right, and we don't know if the ovaries were left intact or if she had her ovaries removed as well. So that was a good question. So we have the, oh, go ahead, Jen.
No, go ahead, Carla.
This is a good question. It's sort of open-ended because this is her question is, I'm interested in RLS and pregnancy issues. What do I need to know? So there's a lot to discuss here. So I'm just going to let you have the floor and just kind of open it up, because this is a hot question that we get at the foundation with pregnancy and RLS.
Is the pregnancy webinar from 6 or 7 years ago still available?
I would have to double check. It should be. We have an update. We updated the website 6 years ago, so possibly.
I did a webinar on RLS and in pregnancy, and we also have a pamphlet, RLS in pregnancy, on for members, if that's of interest to you. Pretty much, I need to know, well, I need to know if you're coming into the pregnancy with RLS, or if you had RLS during a previous pregnancy. And the first thing I'd want to do is get your ferritin level. And if you're thinking of getting pregnant, I'd definitely want a ferritin level and make certain that your iron stores are sufficient. So here's what happens during pregnancy. Your blood volume is going to double. There's no way that any pregnant woman can stop that. Otherwise, she's going to have an unhealthy pregnancy. And then what you need to add in onto that is, in the last trimester, after week 36, the fetus is like a sponge that's going to take all your iron. Because pregnancy is not about the mother, pregnancy is all about the fetus. So there are two things that occur during pregnancy that can three things that can worsen RLS. There are increasing estradiol levels, because although progesterone is the hormone of pregnancy, we definitely need the estrogen component. The blood volume doubles, which means you need more iron, because your body is going to produce more red blood cells, and then towards the end, the baby's going to take the iron that it needs. So we need all mothers to go into the pregnancy being iron repleted and having good ferritin levels. Other than that, what can we do for some of the symptoms? It's been my experience, most pregnant women don't need treatment during pregnancy. They just want to know that they're not going crazy, or that this they're not the only one experiencing this. We would prefer you not to take Requip or Mirapex during the pregnancy, and of course, narcotics are off the table. So I need more specific questions about this. And for those who develop RLS during pregnancy, it almost always occurs in the 3rd trimester when the estradiol level comes down a bit and the baby starts to take the iron, and it almost always goes away. Sometimes immediately after delivery. Nobody can explain that, or within the next few weeks. It does, however, get worse with each pregnancy. So we really want you iron repleted before you get pregnant.
So what is the likelihood that you will develop full-blown RLS because you had RLS during pregnancy?
Oh, I know.
I'm talking later on in life.
I just looked at that and the percentage flew out of my head. I want to say up to 50%.
That's what I thought too in one of the papers. So you really need to stay on top of your iron levels and all that you can to not, to keep it in check as much as you can.
Yes. And give yourself time in between pregnancies. We would prefer at least 12 to 18 months so that your body can recover, which makes it very important after the baby's delivered to go in and talk to your midwife or OB about contraception, because it becomes a high-risk pregnancy. Well, or I should say it's a risk factor. It's called a short interconceptual period. Those patients who come back and have a baby, they're 2 months postpartum and they're pregnant again, and there's a baby every 9 to 11 months. And there's really, it's not like, oh, how could you do that? It's more like, okay, your iron level wasn't good the first time. You bled quite a bit at delivery and you didn't recover, and now you're pregnant again. So we need to watch you very closely. Not only for obstetrical purposes, but if you have RLS, it's not going to get any better. Probably. I can't say for sure. I have a lot of I don't knows, right?
Well, there are a lot of variables because you don't have the full history, and that help. I think that's probably what's going on here. So it's hard to make a remark without that. All right. Well, I wanted to thank everyone for joining us today. This was very popular, Jenny. We had 160 people on that took part of their day to be with you. So I want to thank everyone who joined us, and I hope that you have a great afternoon. And thank you again, Dr. Hensley.
Thank you.
Bye-bye.